In this session, I'm going to talk about the non-opioid therapies as part of the pharmacologic pain strategies. Opioid therapies will be discussed in another module. So we'll outline the different non-opioid analgesics used to treat nociceptive and neuropathic pain, and discuss some strategies to manage pain using different classes of medications as part of multimodal analgesia. And what are some of the keys to effective implementation to optimize pain management? We'll start with ML, who's a 67-year-old woman with parotid cancer with metastasis to the lung, bones, and brain. Originally treated with surgery and radiation to remove the parotid tumor and subsequent treatment with chemotherapy. She has pain in the following locations: facial pain radiating from the cheek to the ear at the post-surgical site that she describes as burning and tingling. Pain to the vertebral spine from the metastasis that she describes as crushing and worse with movement. And chemotherapy-induced pain to bilateral hand and feet that she describes as numbing, burning, and tingling. So when we think about our general approach to managing pain, what is the biologic mechanism of the pain? Is there more than one mechanism? Are we dealing with nociceptive pain? Are we dealing with neuropathic pain? Are we dealing with acute pain or chronic pain? We have to look at the whole person and consider the renal and hepatic function, also the cardiac function, depending on the medication used. And we want to combine pharmacologic and non-pharmacologic treatments, understanding in those with advanced disease, sometimes functional impairment may limit our ability to use some non-pharmacologic treatments such as physiotherapy. And in terms of pain management modalities, pharmacotherapy is the one that we think about the most with people with advanced disease, or for those that work in hospital settings when we're treating acute pain. Understanding that radiation therapy can be a treatment for example, pain to vertebral metastasis. Chemotherapy actually can be a pain management modality if it reduces the tumor burden. There can be surgical interventions that can reduce pain. Neuraxial infusions, this is our epidural or intrathecal analgesia that may be necessary for refractory pain or for acute pain post-surgically. Interventional therapies such as injections, things like celiac plexus ablations for people that have cancer-related pain secondary to pancreatic cancer. And then thinking about integrative therapy, which many of our patients may be utilizing anyway. This is massage therapy, acupuncture, homeopathic remedies, or nutritional supplements. And it's important to know what our patients are using if they're not prescribed therapies, so we can be aware of potential drug interactions or adverse effects. So our treatment plan is based on the diagnosis, and we're talking about here the diagnosis of what type of pain that person's experiencing. But it's also the diagnosis in that fact that a treatment plan may include things like radiotherapy or chemotherapy or surgical therapy to address the pain. And multimodal analgesia, which is the use of medications from different classes to work synergistically to treat both acute and chronic pain conditions to address the complex nature of pain. And when we think about it, we use multimodal therapy, like, for example, when we treat hypertension and we use multiple medications from different classes to achieve a normotensive state. And it includes both our non-pharmacologic recommendations when feasible. And it's important when we think about the setting where we work that we obtain education for the common pain conditions that we may see in our population. You may work in cardiac area, and so you have to think about what kind of pain might you see with someone with cardiac disease or someone who might have pulmonary arterial hypertension and be on medications that can cause significant painful side effects. So we'll discuss some different non-opioid analgesics and their use in the treatment of pain. Starting with acetaminophen, which many of us probably have taken as it's an over-the-counter medication, and even though it's been around for a long time, the exact mechanism of action is still unknown, but it's thought to have both peripheral and central effects. Very weak anti-inflammatory, and often in advanced disease we see it in combination with opioids such as oxycodone and hydrocodone, or we may see this in the acute pain setting as well. And it's often part of multimodal analgesia for acute pain. So we're often seeing patients postoperatively that may be prescribed acetaminophen 1,000 milligrams every 6 hours, alternating with a nonsteroidal anti-inflammatory. The maximum daily dose is 4,000 milligrams daily, but in the elderly, usually no more than 3,000 milligrams daily. Now, it can be used in those with cirrhosis, 2,000 to 3,000 milligrams daily. In my own personal practice, I tend to avoid it when I have challenges with the hepatic function. We do have to remember, though, that acetaminophen is not a benign medication, and overdose with acetaminophen is the most common cause of acute liver failure. Now, while we might not be thinking about overdose in our patient population, for example, I had a patient last week that was taking acetaminophen 1,000 milligrams every 4 hours around the clock, and we saw an acute elevation in her liver enzymes. So it's really important that we query our patients as to how much medication they are taking, especially if it's an over-the-counter medication. Now, nonsteroidal anti-inflammatory drugs, again, most of them or many of them are over-the-counter, and they work by inhibiting prostaglandin synthesis, which will reduce inflammation, pain, and fever. So in patients with cancer, for example, they can be efficacious because inflammatory lesions and bone pain, as they may be opioid sparing. And again, in our acute care setting, we may see it as part of multimodal analgesia after a surgery, where you'll see something like ibuprofen, 600 milligrams every 6 to 8 hours, alternating with acetaminophen, 1,000 milligrams every 6 hours. All of them carry cardiovascular risk, some gastrointestinal adverse risk. Many can increase the bleeding time because they're they decrease platelet aggregation, and the long-term use may cause renal disease. So they're not recommended for chronic use in older persons, and these are people with cardiac and renal disease, and they're on the Beers list, which is a list of medication for criteria for potentially inappropriate medication use in adults. This next table just shows some common nonsteroidal anti-inflammatories and their dosing. Acetaminophen, ibuprofen, naproxen are all over the counter. Celecoxib and meloxicam may have minimal effect on platelet aggregation. And diclofenac, which is also available topically, is a pretty potent anti-inflammatory medication. And speaking about topical agents are often widely used by patients in over-the-counter. They target the peripheral tissue. Their systemic side effects are unlikely because there's limited systemic absorption, and obviously can be easily discontinued because we don't have to worry about titrating or weaning down the medication if there's adverse effects. Now, anesthetics, we have our lidocaine gel or lidocaine 5% patch, which can be useful in many generalized pain conditions. Capsaicin, which may provide relief for arthritic and neuropathic pain, but it's limited by the burning at the site. And then you have your non-steroidal anti-inflammatory gels or patches, which can be prescription or over-the-counter. And you have your over-the-counter methyl salicylate that may provide localized relief for arthritis, such as to hand and knee. Then you have compounded formulations that may include a non-steroidal anti-inflammatory and adjuvant medications such as ketamine and anticonvulsants that can be really effective for neuropathic pain, but challenging because they may not be covered by insurance and can cost up to $300-400 a month, which many patients cannot afford. So the lidocaine patch is a local anesthetic. It's FDA approved for post-herpetic neuralgia. There is a 4% lidocaine patch that is over the counter. It's used for peripheral neuropathy. It's off-label use for stump pain, secondary to amputation, for musculoskeletal pain or myofascial pain, low back pain, osteoarthritis. It's easy to use, usually keeping it on for 12 hours, off for 12 hours, although some people do keep it on for 24 hours at a time. It's got minimal systemic absorption and it's well tolerated. And it's an excellent choice for frail elderly, for those who are sensitive to the adverse effects of oral agents. Capsaicin, I bring it up because there is a high dose patch that's applied by clinicians for post-herpetic neuralgia and can provide pain relief for months. There are self-application with over-the-counter preparations of 0.025% to 0.1%. You have to be careful to use gloves. You need to avoid mucous membranes. There actually is capsaicin patch available as well and can help with multiple conditions, but it's really limited by the burning at the site. And really, it's felt that you needed to do repeat applications to actually be effective. And so in my practice, I don't find a lot of people that have been able to tolerate it. Now we'll move on to talk about adjuvant analgesics. And these are medications that often don't have a primary indication for pain, but they are part of multimodal pain management. But in those with advanced disease, some of them may not be tolerated. And when we think about them, one of the first ones that is tolerated in advanced disease, and we often see it, is our corticosteroids. And so they're anti-inflammatory and may often be used for cancer-related pain. And they're best used, though, for short-term because of the long-term side effect. But when we think about people with cancer, with bony metastasis, visceral distension, for example, from liver metastasis, those with malignant bowel obstruction, or headache secondary to cerebral edema from the cancer or radiation, corticosteroids can be excellent. And when we think about palliative care emergencies where we have a spinal cord compression from tumor involvement or superior vena cava from tumor involvement, corticosteroids can be absolutely essential in these cases. Dexamethasone tends to be the one that we use most because it's got a longer duration of half-life action, once daily dosing, and low doses of 2 to 8 milligrams daily in those with advanced disease who have pain that's not optimally controlled with opioids can be a good choice. However, if in 5 to 7 days there's no benefit, you should discontinue. Now, obviously, we don't usually have to worry about the long-term risk of side effects if we're dealing with someone in the last 3 months or toward end of life. But we have to think about immediate side effects such as immunosuppression or hyperglycemia, psychiatric changes, anxiety, delirium, psychosis. Now, with the advent of immunotherapy that's being used to treat multiple different types of cancers, the use of corticosteroids may be actually contraindicated because we're looking at immunotherapy to boost the immune system to fight the cancer. And so corticosteroids would not be something that we would generally use. And so if you're even considering it, you would want to actually discuss this with the oncologist. Anticonvulsants are part of multimodal therapy. They're the first line for multiple neuropathic conditions, but they're not actually FDA approved for all type of conditions that we use them. The ones that we see most commonly prescribed are gabapentin or pregabalin, and there are many others. Topiramate, is another example of one that I use, but I'm not going to go through them here because the ones that you will generally see are things like gabapentin or pregabalin. Now, they're not without adverse effects: somnolence, ataxia, peripheral edema, weight gain, and there is some increased risk of respiratory distress in susceptible individuals, such as those with COPD or respiratory conditions. And it has come to light in the last couple of years that there's potential for misuse. And so we have to think about that when we're prescribing or working with patients that are taking gabapentin or pregabalin. And then in our elderly, like a lot of other medications, there's increased side effect risk of falls in combination with other central nervous system sedating agents. Now, gabapentin is FDA approved for post-herpetic neuralgia, but you'll see it used for diabetic peripheral neuropathy, low back pain, fibromyalgia, central pain, headaches. You might see it used for chemotherapy-induced peripheral neuropathic pain. You may often see it totally off-label for hot flashes, pruritus from hemodialysis, or metastatic bone pain. It's got few drug-drug interactions, but it is renally excreted, so we have to think about reducing the dose when there's renal impairment, or if we start to see changes in mental status, to be able to check, has there been a reduction in the renal function that's actually causing accumulation of the medication, which can cause sedation and adverse effects. Now, with gabapentin, the oral bioavailability decreases at higher doses. So even though dosing can go from 100 milligrams to 3,600 milligrams daily, you will see decreased bioavailability once you get above 1,800 milligrams. And again, as I said, there's increased concerns with abuse and potential increase in respiratory depression when it is used concomitantly with opioids, which is something that many of us do when we have someone who has cancer-related pain that has a neuropathic component. It's often started at 100 to 300 milligrams daily for 3 to 7 days and then titrated from 1 to 3 weeks up to a max of 3,600 milligrams daily. Now, in renal failure on dialysis, the maximum you may use is 300 milligrams daily. There are extended release formulations, Grelise or gabapentin anacarbol. You can need to see the dosing guidelines. Again, some of the adverse effects and the incidence is listed here. I think dizziness is the thing that we see the most. Edema does occur in susceptible individuals. Now, pregabalin, which is very similar in pharmacology to gabapentin, but it has a more predictable pharmacokinetics and more rapid onset. It's FDA approved for post-herpetic neuralgia, diabetic peripheral neuropathic pain, fibromyalgia, neuropathic pain secondary to spinal cord injury, but like gabapentin may be used off-label for multiple other conditions. It's, again, renally excreted, so like gabapentin, we have to worry about that. But unlike gabapentin, we can see a clinical effect seen in as little as 2 days and is sometimes used in the perioperative setting. Now, it is a controlled substance, unlike gabapentin, because during the clinical trials, patients did report euphoria. The dosing goes from 25 milligrams a day to 300 milligrams twice daily. And again, you're going to see the same type of side effects: dizziness, somnolence, lower extremity edema. When we think about antidepressants for analgesia, now there's 3 different classes of antidepressants we're often thinking about: serotonin, norepinephrine, reuptake inhibitors. The 2 most common ones in this class are duloxetine and venlafaxine, although there are others. And they may be helpful in neuropathic pain conditions. And actually, duloxetine is actually FDA approved not only for multiple neuropathic conditions, but also for musculoskeletal pain. Now, tricyclic antidepressants are old antidepressants, and they're first line for various conditions of neuropathic pain, and you use them at lower doses than depression. But in general, should be avoided. They're on that Beers list for potentially inappropriate medications in older adults. And if we do use them, we should think about nortriptyline, as amitriptyline, which is the most studied, has the most adverse side effect profile. Now, we have to be careful if we're thinking about initiating a tricyclic or a serotonin norepinephrine uptake inhibitor, because there's risk due to serotonin syndrome, especially if we have patients that are already on our selective serotonin reuptake inhibitors. We're thinking about fluoxetine, paroxetine, which don't have any efficacy for pain, but are often widely used for depression. So we'd have to be careful if someone's already being treated with an SSRI for depression or anxiety, that we would potentially not consider using an SNRI or a TCA for the pain. Duloxetine is approved for diabetic peripheral neuropathy, chronic musculoskeletal pain, fibromyalgia, depression, anxiety. And again, I didn't put this on the slide. It is actually also approved for musculoskeletal pain. Again, the biggest adverse effect that you see is nausea, but you can also see somnolence, dry mouth, constipation, anorexia, hypertension, hepatotoxicity, mania, and seizures. So long side effects list, but nausea is the one I see the most. And it's important to start low at 20 to 30 milligrams once daily with food, and you can increase up to 40 to 60 milligrams a day after 1 to 2 weeks. There are some patients that will respond to doses as high as 120 milligrams daily. The analgesic effect can happen within 1 week, but the antidepressant, like most antidepressants, is still going to take probably at least 4 weeks to take effect. As with most antidepressants, you have to taper off to avoid withdrawal symptoms. Now, venlafaxine is another serotonin norepinephrine reuptake inhibitor. It has no FDA indication for pain, but it has seen some positive studies in the treatment of pain for neuropathic pain, such as diabetic, peripheral neuropathic pain, chemotherapy-induced peripheral neuropathic pain, migraine prophylaxis, low back pain, and pelvic pain. Now, it's a serotonin norepinephrine reuptake inhibitor. At lower doses, less than 150 milligrams daily, its primary driver is serotonin, which does not treat pain. So really, you have to get to above 150 milligrams daily to have any pain efficacy. You've got to reduce the dose for hepatic or renal impairment, and it has been associated with QTc prolongation and more blood pressure elevation than you would see with, for example, duloxetine. In my own practice, it's not one that I tend to use, but you may see this in some of your patient populations. Tricyclic antidepressants are actually the most studied. Amitriptyline is the most studied, but it's more sedating, more adverse effects. The doses are lower than used in depression. Common adverse effects are dry mouth, fatigue, or urinary retention. Cardiac risk effects, QTc prolongation, orthostatic hypotension, arrhythmias, tachycardia. You need to use it for about 6 to 8 weeks at a max dose to see if you're tolerated. I'll start at 10 milligrams at night and titrate. Usually, probably for me, no more than 25 milligrams, maybe 50 milligrams nightly. But it's not a medication that I think of, especially in my elderly population or people with multiple comorbidities. Now, if we're thinking about using antidepressants, you've got to really educate your patient that this is for pain, that you're not treating depression, that it could take 2 weeks or more to have efficacy, that the analgesic effect is different from the antidepressant. So I have one patient who's on duloxetine. It worked very quickly for his diabetic peripheral neuropathic pain, but for the antidepressant, the quality of his or symptom, it took well over a month. And you can kill 3 birds with 1 stone, because it may help with pain, it can help with insomnia, some of them, and depression. You've got to think about going slowly and starting low. Otherwise, your older patient will never trust you again, will not even think about retrialing. Now, another adjuvant medications that I didn't even put on our initial list is musculoskeletal relaxants. I don't really use them. They don't really relax the muscle. They work centrally. So we've got our benzodiazepines, such as diazepam. We've got our alpha-2 adrenergic receptor antagonist, which is tizanidine. Your tricyclic antidepressant, which is cyclobenzaprine. Your centrally acting muscle relaxant, baclofen. And it may be effective for some myofascial spasms related to acute injury, but in general, it's not recommended for chronic use. except for tizanidine and baclofen. Of course, we'll see our patients with advanced multiple sclerosis with spasms that may have baclofen actually implanted in an intrathecal pump. Again, you avoid in the elderly, it is on the Beers list. Now, finally, cannabis. I think that at least 1/3, if not more, of the patients that I treat in palliative care are using some form of cannabis. It can be helpful for certain chronic pain conditions, especially neuropathic, but it's not covered by insurance. There are some FDA-approved formulations such as dronabinol, but they're not indicated for pain. It's still not federally legal, although many states have it medically legal for medical conditions or recreational legal. And you're going to have your patients that potentially ask about it. It's not included in this presentation. There is a separate presentation that is available for cannabis, about cannabis if interested. But the keys to implementation is to use medications from different classes. It's often required to manage pain, especially if we have neuropathic and nociceptive components to the pain. And non-opioid therapies can be effective for mild to moderate pain when utilized in the right combinations and doses. But patient education is key to access to achieving adequate pain management, especially when multiple medications are used and when you may need to use a medication over a period of time with titration of doses, such as in our anticonvulsants, gabapentin or pregabalin, to achieve success.